The outcomes that I want you to have really quite simple. I never want you to ask again, what even am I supposed to research for this? Regardless of the amount of information or regardless of the complexity of the topic, I want you to be able to zoom in and identify at least some way that research and this research can help your client and help you help your client in that situation. I also want you to answer the question, is this research paper change, is this modification that I'm doing, is it too much? Am I going too far when I extrapolate that because so-and-so said this in a research paper, that means this can happen? I want to answer the question, or rather I want to answer the myth of, but there isn't a research paper that really applies to my situation. And finally, end with real social validity directly pulled from that research. We're going to start with the research finding framework. Oh, it's 3 steps, my bad. First, we're going to clarify the behavioral principles at play. Then we're going to clarify some relevant demographics, keyword relevant. And then we're going to start comparing and pulling research articles with search terms that actually make sense so that we can identify research that doesn't take us, 4.5 hours to get through and then realize that it's not applicable. So when it comes to clarifying behavioral principles, I want you to imagine yourself in a situation where you just did not know where to go with a client. Maybe that was because you didn't know what goals to program next, like Anne-Marie and Kaylin were talking about. Maybe that's because the behavioral excesses were so significant that you didn't feel like staff or the learner were safe in those situations. Think about a situation where there was just a for lack of a better word, messy clinical challenge. The first thing to get through that web of craziness and to go from this kind of scattered struggle into a solid solution is to get more specific. And I know this somewhat sounds counterintuitive, but in order to identify the correct clinical challenge or hinge point, you need to first identify the details of the situation that are relevant. So get really specific before you get vague. Don't get vague first and then specific. And I'll show you some examples. You want to consider the immediate environment, the motivation, the skills present and not yet present, contingencies associated with the behavior, learning history are just a few things that we need to be looking at. Now, as behavior analysts, we're very proficient at looking at a variety of different variables, and we could spend too much time on this step. So I would say what you really should look at and really zoom in on is what is the behavioral excess or the behavioral deficit or the thing that when taught solves the situation, and what's the surrounding environment. Also look at what's happening instead of that and what's surrounding that environment. If I can borrow a little bit from the nonlinear contingency analysis world, when you look at the behavior that is happening, there's also a behavior that isn't happening. It's not just one behavior that has A, B, C. There's 2, 3 millions of other behaviors that could be occurring, but they're not because of an ABC that is resulting in that behavior not occurring. So specifically look at the behaviors that are solvable or trying to, help the clinical situation, and then what's around those. So for example, you are sitting down with your supervisee or your supervisor, your RBT, a caregiver, and you just hit a wall at the modeling phase, the modeling phase of functional communication. And so you sit down and you're like, they just keep on getting stuck in FCT. Well, the person to give you advice has no idea where to go with that. And likewise, if you had typed that into Google Scholar, you would get hundreds of thousands of articles on verbal behavior and the intricacies of superstitious mans and irrelevant mans, and then modeling versus, verbal prompts versus this and that. But none of that actually answered the question, right? So get specific first. We can use FCRs following a motor imitation prompt, but delaying the imitation prompt has been unsuccessful. Where's the clinical struggle there, right? It's delaying the motor imitation prompt. Your research question has nothing to do with FCT. It's about delaying motor imitation prompts. Client engaged in aggression. Okay, well, okay, so do I sometimes. It doesn't really mean anything to the to Google Scholar if it was an actual person. But entering the classroom, client sits down, work's presented, client gets up to leave, block path, redirect, aggression, etc., etc. Now we have something to go off of. What are some clinical challenges presented in that scenario? Well, it could be a teaching aspect of the para. Why is the para implementing an extinction procedure when the potential increase in the response class is too significant to be handled in that environment? Extinction probably isn't the correct approach there just because we can't handle the increase in response class. What about the toleration skills of the learner? Why aren't they completing the work? What's the ABC associated with that? So we got specific. We just spent all this time talking about how we can get specific. I'm going to take you back into vague. And the reason why we're going to go back into vague is because Google Scholar and Java, they live in the vague because they have to generalize their articles to all of us. So when I say vague, I don't mean go from the first option, progressing in FCT, to a vague question about FCT. No, now that you've figured out your clinical struggle, get vague in that way, right? So instead, attempts to delay motor imitation are unsuccessful, change it to now motor imitation prompting sequence or something like that. We're ignoring demographic variables at this point. We are going to bring demographic variables in, but except in rare cases, they probably aren't going to live in your search terms. The exercise I like to use for things like this is just pretending like you don't want to violate HIPAA, which I guess isn't really pretending because we don't. Or if you're looking through the Cooper book and you're looking through the glossary, describing a challenge to an old and fancy professor. This is the metaphor I used to use in my early days, is if I were to describe this challenge to this person, how would they actually hear me when I say it? We want to get vague on our clinical problem. So you'll see here the continuation of that table. We got really specific and we found that we're having a struggle in motor imitation. Okay, well then let's look at prompt fading and potentially add FCT on there. Arguably, you could just do prompt fading motor imitation. But let's go from, now that we've identified the clinical challenge, let's get zoomed out enough and vague to now start looking at the research term. Escape maintained aggression, school functional analysis and treatment. BST for classroom fidelity, right? Looking at the para situation. So we're taking our specific clinical problem and going to a vague solution that we can type into the search bar. If you look first, what was the thing we started with? Client is not progressing in FCT. What did we end with? Prompt fading FCT. Client engages in aggression, escape maintained aggression, right? So we're going from a vague clinical problem to a vague clinical solution.